Okay. Good morning to everyone that has joined, and thank you for joining live. This session will be available on YouTube later. I'm Dr. Mike Selby. I'm presenting today on a tricky area I think a lot of us are faced with, which is the diagnosis of pseudarthrosis or non-union with relevance to spinal fusion. And this is a very sort of nuanced and complicated discussion, and people have been looking at this area for years and years. So a few things to talk about and a few cases to run through. So good morning to those in Asia Pacific, Australia, New Zealand. Also, yeah, good evening for those in Europe where it's very late, and also my friends in the US, good afternoon and good evening to you. And South America as well. So I'm just having a look to see if we've got any of the regular faculty on along with me. Can't see anyone on at the moment, but I'll try to manage the chat box as things go. So feel free to put some comments in the chat box, but I'm also running through the talk, so I may be a little slow getting to them. I will try to leave time for questions a bit later on. So I put this up on LinkedIn in promoting this topic, and this is a case where these are fairly classic CT images, and on the screen here on the left is a clear case of a non-union. So you can see the cages have subsided. There's incomplete bone growth through the cage. There's a lucency at the end plates. Hopefully you can see my pointer there and there. And then this cage at the bottom at L45 there has subsided into the bone. And, this patient has had a prior laminectomy, standalone construct, and some of this is not that surprising, but that is pretty obvious. And I think most of us would pick that up as a non-union. This case on the right of screen is a little bit harder, and I can tell you this patient is not fused after 5 years. So I did this surgery 5 years ago. It was a 2-level ALIF for a patient that had 4 prior posterior decompressions, a combination of L45 and L5S1 with recurrent disc herniation. And after this ALIF surgery, they felt 80 to 90% improvement in their symptoms overall. And that's partly because when I did these ALIFs, I actually went out the back, took the residual disc fragments, got a good neural decompression. I saw this patient the other day, did a bone scan with SPECT, and these are both still lighting up. They are hot after 4 years. And I'll talk about this a bit more in a moment, but this patient has a non-union. The facets at the back are not fused, and he has some ongoing symptoms, although is substantially better, and we're thinking about offering further surgery. The reason for this patient's non-union is that he freely admits he continued to smoke despite my advice. And to be honest, with this type of titanium 3D printed rough and cage, this is quite a rare outcome in my experience. So I like to talk about cases when I do this, and this is a case, a historic case, goes back almost 10 years. So this is a 37-year-old patient of mine who presented in 2015 with a right arm radiculopathy for about 12 months. And her visual analog score of pain, radicular into the arm, was 9 out of 10. The neck was 6 out of 10. In Australia, we do a lot of CT-guided foraminal blocks. So she had those that helped her for a very short period of time. She got diagnostic benefit from the local anesthetic component, but no ongoing benefit of the corticosteroid component. And she's got 2-level disc degeneration, C5-6, C6-7 with foraminal stenosis. So I won't run down all the slices here. It's not the place to be talking about the nuances of ACDF, but she has also some focal kyphosis. And so, at the time I did what I felt was the standard of care, which was a 2-level ACDF. Now, I may have done a disc replacement on one of those levels now, but back then I think the degree of focal kyphosis worried me, despite the patient's relatively young age. So she had 2 Synthes 0P peak cages, and these have 4 fixed angled screws, 2 cranial, 2 caudal in each device. And I used DBX, so demineralized bone matrix, to the cage and the unsnip processes after appropriate debridement. You can see the bottom little metallic device on that X-ray is a ECG dot from the shoulder, and the devices are well placed, and we've restored foraminal height and restored a little bit of segmental lordosis there. So this is her 6-week review. And sorry, the x-ray here is not from her 6-week review. The x-ray here is from her 6-month review. But at 6 weeks, she had resolution of her symptoms. She was very happy with the result of her surgery. She said she would have it again, but she did return in 2020. So I follow all my patients up long term. During COVID, we did lose track of a few of them. When she returned in 2020, this is her CT scan. So she's got some symptoms starting again. Now, I'm going to tell you, sorry, that's her plain x-ray. Then we're going to go here to when she returned. This is her flexion extension x-ray. So she's then come back 2023 and she's got some more pain and it's now becoming more problematic and limiting her activities and her general function as well. And it's a combination of neck and arm pain and also getting some headaches. And so these are her flexion and extension views. Now, these were read as stable by radiology. But then when you look at these views, it's very important that we actually do some accurate measurements. And so Dan Ryu has published extensively on this. There's a paper from 2003 from Lisa Kaneda, and that was also a very good paper that I referenced in an old JOS article I wrote in 2012 on the radiological assessment of spinal fusion. So you can have a look at these if you want. I think some of the information, particularly in my article, is getting quite old, but Dan Ryu has a bunch of excellent papers in this area. So if we just go back to these views here, Lisa Canada and her group used a threshold for diagnosis of non-union of a measurement between the spinous processes of greater than 2 millimeter difference between extension and flexion. Dan Reuse then refined that and said it should be 1 millimeter. And we know that this is more reliable and reproducible than any form of Cobb angle measurement, which tends to be affected a lot more by rotation. So if you look at this patient in extension and then you look at them in flexion, you can see from those values there, and I've tried to be really accurate drawing these on, that there is greater than 1 millimeter, but less than 2 millimeters in terms of the motion. So now you're in a bit of a conundrum, but I think if you go with Dan Ryu's paper, you have a fairly good indication that this is a non-union across both levels. And Hoitan, who's part of the virtual global spine family, will say this is a very common outcome with these peak standalone cages. So you can do this a little better these days. And Mark Mikhail and his group put up a paper this week. And this was a excellent paper from the Spine Journal on using AI computing methods. I'll just get this video going to look at motion. So as you can see there, he's got flexion extension fingers, and they're using advanced AI to look at the strain properties within the bone, both in the fused segment and at the adjacent segment. And they're comparing these properties. And what that allows is for a more potentially accurate measurement of motion and then putting strain, that orthopedic concept within the bone, into the equation adds to the diagnostic accuracy. So this is an evolving area, but I think this type of research is really important. So this was her CT when it came to revision in 2023. And you can see here, and again, this was called fuse, that the facet joints at those levels, which I've put on the left and the right there of the central sagittal image, that the facet joints are clearly not fused. And so that always to me is a sign, if the facet joints have not shown any changes in terms of spot welding or anything like that, that there is a potential issue there. You can see here in the central part that there appears to be some bone growth through the middle of the cage, but there's also this sort of weird heterotopic bone at the back here, which again, to me, can be a sign of non-union. You can see a little gap there, a little gap there. So this is a concerning CT for me, but you'll often see these reported as fused by the radiologist. This, to me, is the best possible test for diagnosis of non-union in the spine. And this is a high quality bone scan with SPECT. And this shows intense ongoing activity. Now we are 7 years down the line in this area. So when you look at the literature on these areas, and firstly to the right of screen is the case report on using SPECT and CT as an indicator of low-grade infection. There's also a lot of scattered reports on using this as an indicator of non-union, but there's actually very few high-quality studies. So if we go to CT, because we often have thought that is the gold standard, why does CT overcall fusion or get confused with being fused in a lot of cases? And it's basically due to a phenomenon called partial volume average. So what happens is that essentially they have the voxons, which is, let's just say, your voxon is a little cube of information. And if a tiny flick of bone is within that cube, what the CT scan software and scanner will tend to do is fill that whole cube with bone. That's a very simple way of explaining it. And so it can overcall, misrepresent the amount of bone in a section. And look, I think CT is a little more accurate when you're dealing with PEEK and carbon fiber cages or bone-on-bone fusion. I think in the presence of metal, the volume averaging is particularly problematic. Look, it can be reduced, and there are various CT algorithms to do that, but it remains a big area of problem in reporting of spinal instrumentation. So back to my patient. She's had a posterior revision with symptom improvement, actually quite dramatic symptom improvement, has been very happy with the result. This revision was done in 2023. She had a post-op CT at 6 months, which shows progression towards union at the C6-7 level. And I would say that probably is united at the C5-6 level, keeping in mind my previous comments on CT. But I think the thing you can see here is the facet joints are now clearly fused with the posterior debridement and bone graft packing into those joints, along with the implants. And she's got long lateral mass screws at C5, C6, and pedicle screws there at C7. So the posterior revision for these anterior non-unions is a very successful procedure in the vast majority of cases. You can do posterior foraminotomies to release nerves. I find you often don't have to. Just giving them stability results in the remodeling of the sections. But we're talking about pseudarthrosis, or some people call it non-union, and they're not all the same. So there's been a historical classification of interbody fusion success from Brantigan, Steffi, and Fraser. Professor Fraser is from my hometown of Adelaide, so I've always had an interest in this. So a BSF1 is a radiological pseudarthrosis. And this, if we go back to some previous slides, is that patient with complete collapse, loss of disc height, broken screws or plates, displacement of cage, resorption of graft, and then you get that lucency around the end plate. A lock pseudarthrosis, which is what we were really looking at in that previous case, is a lucency in the middle of the cages with solid bone growing in from each end. And a BSF3 is a radiological fusion, and this is really all based on CT scan imaging, which we know, as we just talked about, has weakness. A lock pseudarthrosis is interesting because some patients with this will be symptom-free and incredibly stable because you've done a good neural decompression or you've given them enough segmental stability that they are happy. So this is a BSF1. I put this case up at the start. This patient had some standalone ALIFs and a posterior laminectomy. We won't go into the details of whether or not that was a good idea. It's not my case, but you can see here the lucency in the end plate, the end plate sclerosis. You can see the collapse of the cage. And you can see here bone scan positive across those two levels. Quite strongly bone scan positive. And then in the erect position, you can see the cage is really collapsed. You can actually see a loosened line there as well. So I think most people would say that's a pretty obvious case of BSF1 or complete non-union and complete pseudarthrosis. So at a BSF2, it gets a little bit more complicated. And this figure on the far left is from my JAOS publication. And this shows basically a lock pseudarthrosis. And this was an ACDF done with a standalone PEEK cage and bone grafting. This patient was pretty much symptom-free. We got a CT scan because they had a little episode of neck pain about 3 or 4 years after surgery, but they've been symptom-free, and I still follow them to this date, and they have not had a revision some 15 years after this initial surgery. So with this kind of appearance, though, this is a quite obvious radiolucent line through the middle. And my theory on these patients is that this can almost be protective. If the patient gets good relief of their arm pain with a good decompression, and you have a little bit of micromotion through that lock pseudarthrosis, as long as they don't redevelop big bone spurs or need to do a lot of remodeling through the segment, then these patients, it kind of acts like a well-constrained TDR. So it's not the end of the world. So these are not definitive revisions. You would only revise these patients, in my practice, if they have significant symptoms that correlate with recurrent pseudarthrosis. Dr. Rafe Mobbs, who's written a lot on ALIF, he's written a lot on pseudarthrosis. He's a friend, colleague, and mentor of mine. He sent me some pics when he knew I was doing this talk. So this pic on the right is from his long-term follow-up SynFix study. So the long-term follow-up of the SynFix is showing what he and his radiologist called as fused across the cage, a clear lock pseudarthrosis. And you can see this on the CT scan through here. You can see a little bit of haloing around the SynFix screws. And the SynFix device is almost the same as the device I showed in the neck, 0P, in terms of angular fixed screws that provide stability. But he's gone back and looked at his results and sent a further slide of another cage, another SynFix, which looked like it was fused solidly and was called solidly fused. But he still has a radiolucent line through there. So it's an issue we're all seeing and we're all facing. So this is a case, and again, I won't show all the slides and go into all the details, but this is what I call a BSF3. This is a 2-level ALF backed up with percutaneous pedicle screws, which I did in approximately 2020. And in 2022, she had a CT scan, which shows what I feel is solid bone growing through the titanium cages. There. You can see no lucency around the plate. There's not a huge amount of end plate sclerosis. There's no sort of punched out erosions or lesions around the margin there. Now, she came back in 2024 with progression of her already present adjacent segment disease. And to be, fair to myself, she already had changes through 3, 4, 2, 3, and 1, 2. Before I even did this, we just focused on her most problematic segments with neural compression at that stage. So in her workup for potential extension, I got a bone scan with SPECT. Now, you can see a vast difference between this bone scan and the one I showed previously. So here, it's almost quiet. And you can see this is a sort of 4-year follow-up, but there is not much activity on a high-quality bone scan through the solidly fused segments. In fact, the activity, as you'd expect, with the progression of ASD is at the L3-4 level, both interspinous and through the disc, and at the L1-2, and there was a bit of activity in the L2-3 facets. So we come to another case, and this is another instructive case on a patient who'd had 4 prior spine surgeries and then developed adjacent segment disease. So this is a patient who is in her 80s, and she's got what I diagnosed as a non-union of an L3-4 TLIF. Now, you can see her lumbar flexion extension views up there because people were suspicious for a while that something was going on with this patient. Her erect and flexion extension views, the lumbar spine, were non-diagnostic. Both a radiologist and her previous operating surgeon felt that these were stable. This cage was stable and had a CT scan called as a solid fusion. Now, this is a great difficulty with titanium implants and interbodies. So she had not had a bone scan with SPECT. I organized that, and you can see the below picture not only shows her adjacent segment disease evolving at the L2-3 level, but at L3-4, where there is a titanium TLIF interbody cage, there is a lot of ongoing activity, and this is way too much activity for 3 years plus down the line. So she had some medical comorbidities. She'd had a spinal cord stimulator with some relief of her leg pain. She has severe lower back pain, and she can't stand up straight. A tricky situation for potential revision. These are her films. So you can see her long films show implants from L3 to S1. We know that she has a solid interbody fusion from L4 to S1, but L3-4 is loose. You can actually see on the MRI some progression of adjacent segment disease at L12 and L23. So we're faced with multiple issues here: adjacent segment disease, L1223, L34, TLIF non-union titanium cage. So we took this on surgically with revision using a prone lateral approach where we can simultaneously access the posterior implants for removal. And this is just a little video of us starting the operation posteriorly. We're able to use Wiltse approaches via a midline skin incision to remove the implants, sort of minimizing the surgical trauma to the patient. I do find getting implants out that I didn't put in through percutaneous screws, through percutaneous stabs, quite challenging. And then we set up for prone lateral. And the first level we took on was a prone lateral revision of this TLIF cage. And you can see the little window we get there in the prone lateral position with the retractors all set up. And this is Dr. Simon Clark, my friend and neurosurgical colleague, and I operating together. And he is operating at the back of the spine to provide some distraction here, while I use the prone lateral window to try to retrieve this TLIF cage. Retrieving titanium cages can be challenging. PEEK can just break up with an osteotome and you can retrieve it piecemeal, but titanium implants are a bit of a different story and can be quite challenging. But having control at the back while we retrieve the cage from the side was quite helpful. So you can see here, this is the cage on the fluoro shot. You can actually see at the bottom of that picture there on the right, the cage within the disc. It just gets a bit washed out with the light, but that little metallic object there is the cage. Oh, sorry, a bit of volume there. Let that go. This is, I'll just play it again so it's a little loud. See if I can turn it down. It's got a little volume there. Hopefully we're not swearing, but this is us using a hip revision hook to get cement out, to try to loosen up the cage and then bring it out. And that's the cage being delivered. And there's the cage being delivered with the type of hooks that you can use to actually get into titanium implants and pull them out. And when we pulled this thing out, there was no bone growth through the cage. It was just bone graft substitute still in its almost liquid form within the center of the cage. Now, these bone graft substitutes contain radio-opaque material. So a lot of the time, if the substitute stays within the cage and doesn't reabsorb, it looks like it's fused. It's a mistake that Dan Ryu talks about in cervical spine a lot, and we also see it in the lumbar spine. You can easily get fooled by these grafts, and you have to know what graft was put in there to know if you can be fooled by it or not. And these were all the implants that came out. You can actually still see there at the top, that TLIF that came out, the cage, that graft material still inside. So there's no bone in there. That is just graft material. So after we retrieved the cage at L3-4, we put a prone lateral expandable titanium cage in there with allograft, and likewise at the two cranial levels suffering from stenosis and adjacent segment degeneration. I know that this is not a perfect reconstruction, but for a patient in her 80s, I think her sagittal balance is appropriate, and she has done very well following the surgery and been very happy with the overall result. So I think that's another case that just demonstrates the difficulty with diagnosis and management of these pseudarthrosis cases, where the findings can be very subtle. And to me, it would have been a mistake there to just address the adjacent segment disease and to not also address the non-union at L3-4. So I'm going to allow some time for any questions on the chat, but that is my rundown of the current state of play. I do think, just going to flick back here, that we need to do a lot more work on correlation of SPECT like this here with non-union. Certainly been done before, but they're small case series. There isn't good data on it in terms of data that in some environments you can present to your insurance company that's approving scans. I know availability of this type of high quality bone scan with SPECT can be challenging. And I do think it's an excellent way of helping manage these type of problems. It's also helpful assessing patients for adjacent segment disease, sacral iliac joint pathology, and other potential pain generators. You don't have to rely purely on a bone scan. You can then use your diagnostic blocks, local anesthetic, and see how a patient responds to those. But to me, this is a very important modality, and I hang my head in shame because when I wrote my JS review paper on this in 2012, I barely mentioned, or I don't think I even mentioned bone scan with SPECT. So I really should have. And I use it a lot now in my day-to-day practice, which is heavily revision focused. I will see if there's any questions on the chat. I thank everyone for joining me. Just flick back through. This is a discussion that we can get into on LinkedIn. I'll just pop that up if anyone wants to join us on there. You follow along. I think Ali Baj made, who's our fearless leader of the virtual Global Spine Conference, made a very good point on LinkedIn about this exact issue, in that a patient that does well after a fusion, but then starts to do poorly after 6 to 12 months without another obvious reason is a lock pseudarthrosis or a pseudarthrosis until proven otherwise. And I would agree with that quite strongly, that you always have to look into it. I think labeling our patients with failed back syndrome when we haven't adequately excluded a lock pseudarthrosis is a massive mistake. And I think to work towards that, we need to get some better evidence for bone scan with SPECT. And we need to be using tools like the AI tool for detection of cervical non-union. With the cervical non-union, I think that is an excellent paper, and I'm hoping you can do the same for lumbar as well, because I do find the flexion extension views there a lot more unreliable. And if something can be done with that, I think it would also help with a basic aspect of diagnosis and management. So I'm going to jump on the chat box now. I'm just going to see if there are any questions. I'm just going to see if any other members of our panel have joined. I'm not sure if any. Oh, I see Matt in the background, but I don't know if he wants to jump on and ask any questions. Thank you for those saying thanks. This is an area of interest of mine, and I think I wouldn't mind actually sort of presenting on this again, some more on the on management and taking out TLIF cages in the various different ways you can do it. So I just want to say thank you to everyone for joining me, and if you've got any questions, feel free to reach out on LinkedIn. As always, I'm not sure of the topic for next week, but we are back on again next week with one of the other presenters from the panel, and I'm sure some excellent guests as well. So thank you everyone for joining, and I'll see you next time.